Case study number 1, client J with TBI.
According to Trombley, people who have had a TBI with alteration in brain function as a result of some external force often undergo changes in their ability to carry out valued roles, tasks, and activities as a result of impairments in cognitive, behavioral, emotional, and/or physical functioning. Moderate to severe brain injury affects virtually every area of life for the survivor and their family. Changes in capacities and abilities may affect an individual's functioning for months, years, or decades. Each year, approximately 1.7 million people in the United States sustain a TBI. Out of these, 3% die, 16% are hospitalized, 80% are treated in the ER and released, and an unknown amount are seen in the ER but are not released with TBI diagnosis, seen outside of the ER, or don't seek care. 80 to 90,000 Americans experience a new onset of disability resulting from TBI each year. 3.1 million children and adults in the U.S. are living with a lifelong TBI-related disability.
After children ages 0 through 4, older adolescents aged 15 through 19 have the highest rates of TBI-related emergency visits. Adults aged 75 and older have the highest rates of TBI-related hospitalization and death. Regardless of age, rates are higher for males than females. Between 2002 and 2006, falls were the leading cause of TBI among all age groups in the U.S., followed by motor vehicle traffic accidents, striking against or being struck by an object, and assault. Alcohol use is a contributing factor to many events that result in a TBI, which estimates that 1/3 to 1/2 of people who sustain a TBI were intoxicated at the time of injury. Pre-injury alcohol use has implications for outcome, treatment, and long-term adjustment to TBI. Patients who were intoxicated when injured reportedly have longer hospitalizations, longer duration of excesses in behavior related to agitation, and lower cognitive status at discharge than those who were not intoxicated. Furthermore, a history of TBI increases a person's risk of TBI. After one TBI, the risk of a second may be up to 3 times greater than for those who have never sustained a TBI, and after a second TBI, the risk of a third injury may be up to 8 times greater.
A TBI can be classified as open, penetrating or perforating, or closed, static or dynamic, based on the biomechanics of the injury. In an open brain injury, an object, such as a bullet, enters the cranial cavity. It is considered a penetrating or perforating injury depending on whether the object remains lodged in the cranial cavity, penetrating, or passes through and exits the cranial cavity, perforating. The extent of damage depends on the shape, mass, direction, and velocity of the object. A TBI that results from a direct or indirect impact without penetration of the brain tissue is classified as a closed brain injury. Closed head injuries can result from static or dynamic loading. A dynamic loading injury occurs when there is rapid acceleration and deceleration of the brain. A static loading injury, crush injury, occurs when a slow mechanical force is applied to the brain. For example, if the head were trapped under heavy debris after an earthquake. The damage from a closed brain injury is directly related to the type and amount of forces generated during the traumatic event, for example, shear or tensile forces.
Blast injuries has recently been recognized as a specific type of TBI. A blast injury results from any type of blast explosion, including IEDs, improvised explosive devices. A blast TBI can occur in conjunction with an open or closed brain injury. Brain injuries can also be categorized into focal or diffuse injuries based on the extent of the pathology. Focal injuries result from brain contusions, lacerations, and hematomas. Focal lesions occur when the brain hits the skull and scrapes over the irregular bony structures at these locations. The occipital and parietal lobes have smooth surfaces and are less likely to incur damage. Focal lesions to the prefrontal and anterior temporal areas affect modulation of memory, emotion, and drive. Damage to the orbitofrontal areas generally results in impulsivity, whereas damage to the frontolateral cortex results in hemiparesis, impulsivity, and attentional impairments, as well as decreased mental flexibility. Diffuse injuries typically occur in motor vehicle crashes where there is rapid movement of the head. A traumatic axonal injury is a type of diffuse injury that results when the brain accelerates, decelerates, and rotates inside the skull. The brainstem is more stable than the cerebrum, which rotates around the brainstem during impact. The rotation places shear force on the long axons that transmit information throughout the brain and brainstem. Some of the effects of TBI include hematomas and contusions, as well as altered states of consciousness, ranging from complete consciousness to complete lack of consciousness. Motor functions can be impaired as well, leading to weakness in coordination and impaired balance. Cognitively, the client may experience diminished mental processing speed and deficits in attention, as well as memory impairment and confusion. They may also experience reduced capacity for higher level cognitive functions and decreased metacognition. Some of the behavioral and emotional outcomes include irritability, impulsivity, anxiety, aggression, depression, and agitation. Damage to the brainstem and cerebellar pathways can lead to ataxia, diplopia, and dysarthria. Comorbidities due to CBA or a fall include fractures, spinal cord injuries, and chest and abdominal trauma.
Occupational therapists are key rehabilitation professionals in assisting individuals with TBI to reintegrate back into their community. An OT's education and training make them experts at evaluation and analysis of an individual's performance abilities relative to the demands of the activity. This perspective encompasses all aspects of an individual's life, including ADLs and IADLs, rest and sleep habits, work demands, play, leisure, and social participation. OTs can help clients relearn how to do activities, remediate, or determine new ways of accomplishing them, compensatory strategies. Through guided, graded instruction within the context of the client's community, OTs may work with individuals in real-life settings or any other environment in which they need to regain competence in occupational performance.
Occupational therapy for inpatient rehab. Assessment. OTs often begin by screening vision, visual perception, and cognition. OTs must first determine the extent to which patients can scan, attend, follow, and retain instructions to interpret performance on other assessments, examples such as ROM, manual muscle testing, and ADLs. Although referral patterns may vary, patients can generally participate in intensive inpatient rehabilitation when they demonstrate stimulus-specific responses and when post-traumatic confusion and agitation either resolve or do not prevent a barrier to participation in intensive therapies. When a patient progresses to Rancho Level 6, which is Client J's current level, they remain inconsistently oriented but begin to be aware of appropriate responses to staff and family and demonstrate carryover for relearned familiar tasks. The complex interaction of factors associated with impairment, context, and environment require a multiple disciplinary approach to treatment. OTs who work with TBI patients must appreciate the contributions and expertise of other team members as they offer the patient what is unique to occupational therapy.
OT for inpatient rehab. Treatment. OT treatment during inpatient rehab is aimed at optimizing motor, visual, perceptual, and cognitive functions, restoring competence in fundamental self-maintenance tasks, contributing to the patient's continuing behavioral and emotional adaptation, and supporting the patient's family as they prepare for discharge. To optimize motor function, OTs can engage patients in gross motor activities that they can perform almost automatically, such as playing catch or hitting a punching bag. These activities minimize the demands on weakened cognitive functions such as attention, concentration, and memory. Approaches should best match therapy goals and the patient's abilities. TBI frequently results in foundational visual and/or visual perceptual disturbances that impair occupational function. It is important to identify possible visual impairments as soon as possible so that appropriate patients are referred for specialized optometry and/or ophthalmology assessments, and therapists can make an effort to circumvent the influence of visual impairments on performance. Intervention for primary visual deficits emphasizes environmental adaptation, compensatory techniques, assistive devices, and patient and family education. As far as cognitive function, inpatients with TBI are typically in a period of relatively rapid improvement, so OTs provide cognitive remediation activities and exercises to challenge and stimulate primary cognitive domains, such as attention, memory, and executive function, in the hope that natural recovery will be enhanced and accelerated. Inpatient rehab helps patients reacquire basic self-care and self-maintenance skills, such as bathing, dressing, hygiene, and eating. In general, a given task is simplified until the patient is consistently successful in performing it, and then the complexity is gradually increased while the externally provided structure is gradually decreased. OTs also assess the patient's ability to handle more complex activities, such as meal preparation and cleanup, laundry, and using the telephone. OTs also take into consideration the client's prior familiarity with the task to determine whether the client will be reestablishing familiar habits and routines or learning new or relatively unfamiliar skills.
The behavioral sequelae may intermittently influence the patient's ability to participate at this stage. Brain damage itself may cause psychosocial changes, such as irritability, aggressiveness, or apathy. As the patient becomes more alert, their awareness of the situation may increase irritability, uncooperativeness, or mood fluctuations. It is important for OTs to recognize the state of internal chaos and vulnerability of TBI patients. OTs should avoid placing patients in situations that are fraught with frustration and failure, and instead structure experiences that reinforce patients' confidence that they still have the potential to accomplish things. Patients' families continue to require information and support to understand the recovery and rehabilitation process and to inform their decision-making in discharge planning. An OT should provide the family with information about the full spectrum of possible TBI outcomes to enhance realistic expectations, the effects of TBI on family systems, and possible alterations in family dynamics post-discharge, the benefits, challenges, and responsibilities of caretaking and supervision post-discharge, and resources available for post-acute rehabilitation. Family participation in rehab sessions can help the family members learn about the patient's strengths and weaknesses, techniques for helping him or her optimize performance, and help minimize expectations of an abrupt recovery to the same person the person was before the injury.
There are several post-acute rehabilitation options available. Of note is that Client J will be heading to a comprehensive holistic day treatment program. In general, the aim of post-acute rehabilitation is to prepare the client to re-enter the community. After discharge from acute rehabilitation, many clients require occupational therapy treatment aimed at teaching them to compensate for residual cognitive and visual perceptual impairments so that they may resume self-maintenance, self-advancement, and self-enhancement roles. Areas of focus during OT may be on optimizing cognitive, visual, and visual perceptual function, restoring competence in self-maintenance roles, leisure, social participation, and work, and contributing to behavioral and emotional adaptation.
For each client, an occupational profile is created to find out information about needs, problems, and concerns about performance in areas of occupation. Occupational performance is analyzed through screening and evaluations. The analysis focuses on collecting and interpreting information using assessment tools designed to observe, measure, and inquire about factors that support or hinder occupational performance.
For our case study, we have Client J. She's a 54-year-old female with a past medical history of chronic back pain and anxiety. She lives with her husband, adult son, and daughter nearby in a 2-story home. Her home environment consists of steps into the home and a flight of stairs. Her leisure interests include being a volunteer at her local hospital, shopping, playing cribbage, and Sudoku. She has private insurance.
Client J's medical history includes her reason for referral, which is a traumatic brain injury following a motor vehicle accident. Her medications include a multivitamin, Ritalin, Prevacid, Singular, and Coumadin. She has no known drug allergies. She is a smoker, and she is currently at Rancho level 5 to 6. As previously mentioned, Client J is a Rancho level 5 to 6. Level 5 consists of confused, inappropriate, non-agitated, person is confused and responds inaccurately to commands. Level 6 is confused, appropriate, person is confused, responds accurately to commands.
Client J has several strengths. The left side of her body is within functional limits. She has a familial support system. She's motivated to participate in therapy, has adequate financial resources, and was independent in ADLs and IADLs, leisure, driving, and other activities prior to admission.
Some of Client J's weaknesses include decreased function of dominant right upper extremity, increased tone in her right upper extremity throughout the limb, decreased strength in her right lower extremity, decreased cognition levels in multiple areas of cognition, decreased safety awareness, impulsivity and agitation, right neglect. She also requires moderate assistance for transfers and is experiencing shoulder and wrist pain with passive range of motion. OT domains, Client J. These are the areas that are of particular importance to the case of Client J. This mind map illustrates the dynamic interrelatedness among the 6 different aspects of the OT domain, which are areas of occupation, performance skills, performance patterns, client factors, activity demands, and context and environment.
Occupational performance areas to address for Client J include ADLs, IADLs, leisure, social participation, and work. OT areas of focus include addressing cognitive issues, regaining motor function, and regaining occupational functioning.